So we're going to finish the spinal cord injury PowerPoint. We're talking about different cord syndromes depending on the part of the spinal cord that is injured. Moving on to the anterior cord, this is damage to the anterior portion of the spinal cord, and this often happens with flexion type of injuries. As you can see, this will affect the spinothalamic tract, and depending on the exact location of the lesion, different parts of the body may or may not be involved. You can see with the image here, based on the location that is involved in the anterior horn, you can involve the cervical, thoracic, lumbar sections. In this example, this sacral segment is not included. We will also affect the motor tract, again, as well as the spinothalamic tracts. Oftentimes, these anterior lesions are bilateral, so we will see motor and sensory characteristics bilaterally. With central cord syndrome, this will be damage to the central aspect of the spinal cord. This often occurs with hyperextension injuries, especially in the cervical spine. We're often going to see more severe neurological involvement in the upper extremities compared to the lower extremities, and our peripheral fibers may not be affected. You will often see the pattern here on the right, with the upper extremity involved and the lower extremity intact. With Cauda-Equina syndrome, this is damage to the distal end of the spinal cord. We know based on our anatomy that below the levels of L1, L2, and the spinal cord, we start to see peripheral nerve roots. So damage to these levels will result in sensory impairments, muscle weakness, and changes to bowel and bladder. The sensory distribution is in the image here. Okay. And this term that we will often refer to for the sensory distribution is called saddle paresthesia. The idea is that it affects the area that would be in contact with the saddle if you were to sit on a saddle on a horse. Because we are affecting the nerve roots with Cauda-Equina syndrome, we are actually going to see lower motor neuron symptoms. And there will often be a change in bowel and bladder control. Now, this is actually considered a medical emergency, so if you are working with a patient that has changes to bowel and bladder function, they report saddle paresthesia, that is something that we are going to immediately seek help for. We talked about muscle tone a little bit already, but we're going to go into that a little bit further. So acutely after a spinal cord injury, especially if there is damage to the motor tracts, we're often going to see muscle flaccidity, and our reflexes may be absent below the level of the lesion. However, over time, we often see an increase in the resting tone of muscles, and reflexes tend to reappear. Now, oftentimes, spasticity can later be seen in patients with a spinal cord injury, and this will occur with excessive amounts of stimulation. So this could be an infection, this could be a fracture, any type of new injury. If the patient becomes constipated, this excessive amount of stimulation will increase the spasticity or the tone in the patient and make it worse. So essentially, any increase in stress, things like change in temperature, will make their muscle tone or their spasticity worse. The autonomic nervous system is also going to be affected after a spinal cord injury. This is particularly important for people with lesions that are above the level of T6. So essentially a level T5 or above is going to have issues with the autonomic nervous system. So if we have any adverse effects with the autonomic nervous system, this is called autonomic dysreflexia. And this, again, is a medical emergency. So this occurs when there is a noxious or a painful stimulus, and the body will elicit that sympathetic response. So we're going to get vasoconstriction of our blood vessels, elevated blood pressure. In someone with an intact spinal cord, the descending sympathetic output will help to compensate for these elevated blood pressure levels by vasodilating. However, someone with a spinal cord injury above the level of T6, these descending signals will not get through, and the excitatory signals from the sympathetic system will continue to vasoconstrict and continue to elevate blood pressure. So this is a medical emergency. So oftentimes we are going to see symptoms such as sweating, flushed skin, headaches, chills. If this is not treated, if the noxious or painful stimulus is not removed, this can lead to seizure, myocardial infarction, and ultimately death. So again, the way that we treat this is we remove that noxious stimuli. Now again, this can be something as simple as having an overextended bladder. So if their bladder is full, if they are on a catheter and the catheter is backing up into the bladder, this could be from something sharp stabbing into their foot, changes in temperature. So it's things that we might think of for someone without a spinal cord injury that would not be considered noxious. Someone with a high level injury, so above the level of T6, this is considered a noxious stimulus. Okay, so again, this is a medical emergency, and we treat this by removing that noxious stimuli. So as I mentioned, some of our causes can include a urinary tract infection, having a full catheter that's potentially backing up into the bladder. The bowel could be impacted. At the skin, we can see pressure sores, something as simple as an ingrown toenail, a sunburn. All of this can contribute to those symptoms. Again, those signs and symptoms include hypertension, bradycardia, headaches, seizures, and blurred vision. So other changes that we're going to see in our patients with spinal cord injury include skeletal changes. So we may see hypertrophic ossification or myotropic ossification. These often occur below the level of the lesion. Research actually is unsure as to specifically why this occurs, but it is a very common thing in patients with spinal cord injury. This could often be due to the trauma of the initial injury. However, it has been seen in patients years after the initial injury. Because of their limited mobility, you will often see contractures, scoliosis, and altered bony alignment. Pain for these patients can also occur because of poor posture, because of potentially overuse of specific musculature, joint and tendon degeneration can all be contributing factors to pain. Fatigue is also a common symptom in patients after spinal cord injury. Autonomic nervous system changes and poor thermoregulation can cause poor tolerance to physical activity. This often affects the psychological well-being of these patients because, again, these are typically young, active male patients that are injured. Depression is a common problem with these patients, and lack of involvement in physical activity can also contribute to fatigue. Respiratory problems in these patients will be life-threatening. So if you remember, our innervation of the diaphragm is C3, 4, and 5. So lesions above the level of C4 are going to affect the innervation of the diaphragm. They're also going to affect the muscles of inspiration and expiration. These individuals may often need assistance with a ventilator, and they're going to be at high risk for aspiration and for pneumonia. So this is an image of a skeletal change. This individual is paralyzed by a gunshot wound. If we look on the first picture on the left in A, we can see the bullet still in here. But what they have here, these measures, this is a 30-degree initial curvature from the injury. Picture B in the middle is 7 years later, and we see a severely increased change in the curvature to 110 degrees. And then what they did to treat this was they did a surgical procedure to realign the spine, and they did a fusion. You can see a very, very large fusion, and they corrected the curvature back to just 53 degrees. Looking at our cardiovascular changes, there's going to be an increased risk for DVT and PE, that pulmonary embolism, in these patients. Again, we said physical activity is going to typically be lower in patients with spinal cord injury, so again, that increases their risk for cardiovascular issues. Again, if someone is at risk for autonomic dysreflexia, this will often lead to hypertension, variability with heart rate, and decreased cardiovascular response to activity. So that means when they do participate in activities, their cardiovascular system is not as efficient at responding to the demands placed on them. Metabolic changes, we're going to see a change in carbohydrate metabolism in these patients. This can often lead to insulin resistance and diabetes. Usually acutely after spinal cord injury, more specifically in more your tetraplegic patients, we're going to see muscle atrophy, which is then going to lead to increased body fat and a decreased bone density. And all of these metabolic conditions or changes that we see are going to increase the risk of cardiovascular conditions in these patients. Pressure ulcers are also a common complication of spinal cord injury. This primarily occurs because, again, of immobility and increased pressure over bony prominences. So we will teach our patients to commonly shift their weight and constantly be moving around to relieve pressure or decrease pressure on specific areas. However, this is often something that takes a little bit of time for them to practice and get used to. Poor nutrition, lack of care, and smoking are all going to increase the risk of developing pressure ulcers in this patient population. Bowel and bladder control, again, will be affected in patients with spinal cord injury. So patients can have what's called a reflexive bladder or a non-reflexive bladder. So a reflexive bladder is when there is a spasm of the bladder and these patients are unable to void or empty the bladder. And they will often have muscle hypertrophy within the bladder. A non-reflexive bladder will be a flaccid bladder with decreased tone. So oftentimes what these individuals will do is they will be on a bowel and bladder schedule. So they will have their own pattern and they will either catheterize themselves or they will have a routine so that they are always using the bathroom at the same time of day. This does help keep them regular. Because of these issues, urinary tract infections and kidney stones are common in patients with spinal cord injury. Sexual dysfunction will change, or I should say sexuality will change with these patients. So again, it depends on the level of the spinal cord lesion and whether it is complete or incomplete. So there are two types of categories. So if a male has a upper motor neuron lesion, we tend to see more of what's called a reflexogenic type of function. So in these male patients, they're able to achieve an erection, but they will not be able to ejaculate. With a psychogenic, which is a lower motor neuron dysfunction, it will be harder for them to achieve an erection, but they can more easily ejaculate. In women, after spinal cord injury, typically menstruation will stop for 3 to 6 months. However, when it does resume, oftentimes this can be a contributing factor to autonomic dysreflexia. Females with a spinal cord injury can have a safe pregnancy, however, they should be monitored very closely. Sleeping disorders are also very common in patients with a spinal cord injury. They will often have issues with sleep apnea, more particularly in the higher level patients, and this will lead to decreased oxygen saturation and can contribute to cardiac arrhythmias. Oftentimes you will see bracing used, particularly if the vertebral column and the spine is unstable initially after an injury. These are just 3 different types of examples of braces that may be used. You can see image C here is a halo vest. This particularly is going to restrict the thoracic and cervical spine. So disability associated with the level of the injury. So this is going to depend on what is affected. So in our C1 through C5 level patients, so our quadriplegia or tetraplegia, so these individuals will need help with dressing and bathing. They will be independent with communication, but they will also use assistive devices. For our C6 to our C8 level patients, this will be a little bit more variable. However, they should be independent with bathing and dressing, but they may need assistive devices to help with that. Without these assistive devices, they may need minimal to moderate assistance, but they should be independent with verbal communication and can use assistive devices. Our T1 and below patients will be our paraplegics, and they will be independent with dressing, bathing, and communication, and they may need assistive devices but should be fairly independent.